Hey everybody, it is Dr. Wood, and yeah, we're doing this online because Hurricane Dorian decided to interrupt our plans. But like all things in medicine, we must be flexible. So since it is Labor Day, I've decided to labor to bring you some excellent online content here to YouTube. But anyway, so let's continue on. I basically want to finish up the antibiotic section here. I will then also record and post up the ENT section, and that should get us pretty well caught up to where we will do ophthalmology on the following lecture. We'll then wrap that up, have a review via Kahoot, and then that should be it right before the test, right? So anywho, let us continue on. We were discussing different antimicrobial agents. Metronidazole or Flagyl is going to be another one of these. It is used quite commonly in the clinical realm. We've already kind of alluded to it previously. This one has a little bit of a novel mechanism compared to some of the other things that we've seen. This one will actually bind to bacterial DNA and actually will cause it to lose its helical structure, and that leads to more strand breaks, and then that triggers off apoptosis and kills the bacterial cell. You're going to find that its activity is fairly narrow. However, it is pretty good at what it does, even though it is fairly narrow in spectrum. Mainly, this is going to be covering your anaerobes, gram-positive and gram-negative anaerobes. And so, as I mentioned, this is a really good one to use for things below the diaphragm, mainly intra-abdominal infections. This is really good for sexually transmitted infections, potentially. This also covers some parasites, interestingly enough, which makes it good for some vaginal infections there. So that's pretty handy from that standpoint. The other thing you're going to find with this one is that it does treat Clostridium difficile, and so the other drug that we talked about that covers C. diff is vancomycin. If you recall, vancomycin, while usually given intravenously, is given orally for the treatment of C. diff, and if you remember its structure being quite large, it didn't really have any appreciable oral absorption from that standpoint, which is good because that limits systemic side effects. Metronidazole, on the other hand, can actually be used either IV or PO for Clostridium difficile. So this is one you can use either or, depending on the severity of infection. I've seen some patients will get IV Flagyl and then PO Vanco. That is certainly something I've seen for more severe C. diff infections. It just depends, though. Right, so those are the main uses you're going to see for it. Topically, you can also see it being used for certain things like acne and things like that. As far as side effects go, headache, nausea, vomiting, those are pretty typical of most medications here. The interesting one here is this disulfiram-like reaction with ethanol. And so disulfiram is actually a compound. It was used to try to deter people from abusing alcohol. And basically what happens is that ethanol itself undergoes this two-step process for elimination. It gets broken down by something called alcohol dehydrogenase into a product called acetaldehyde, and then acetaldehyde gets broken down by an enzyme called acetaldehyde dehydrogenase. I've probably mentioned this before. What happens when you have the disulfiram around, that actually inhibits the aldehyde dehydrogenase, and so you end up building up this acetaldehyde after drinking alcohol, and it can lead to a lot of flushing, it leads to nausea, vomiting, patients feel very hot and like they're going to throw up, and it's a pretty miserable experience there. But the idea of giving disulfiram to those patients who are alcoholics would be that if they were to relapse and then drink alcohol, they would then throw up and feel horrible, and then they wouldn't want to do it anymore. More often than not, they just didn't take the disulfiram, right? So, however, there are several drugs that can actually cause the same reaction here, and so metronidazole is sort of the poster child for that. So, most likely end up being like a board-style question where it says a patient was on antibiotics for something, and they had alcohol, and now they come in and they're all flushed and whatnot. Again, it's not an it's not an allergic reaction. It's just a natural reaction of this disulfiram effect of it inhibiting acetaldehyde dehydrogenase. So avoid alcohol with it is the main thing to take away from that. Tell patients just don't drink while taking metronidazole. I actually had one interesting case where I had another pharmacist who was a coworker of mine. His wife was actually taking metronidazole for some rosacea, and she actually went to a restaurant and had alcohol and started to get super flush. And what was interesting is that she was actually taking topical metronidazole, which is not something we normally think about causing a big reaction, but it really just got super flush and hot, and that was really the only reaction that she had from it just being used topically. So it can happen via any route. Again, avoid using alcohol at the same time. That's really the big thing to take away. So a couple of other ones, Polymyxin B and E. These are going to be agents you might see being used more topically more than anything else. It's actually an antibiotic that is produced by this Bacillus polymyxa. Occasionally, though, we are seeing them being used intravenously if we have really resistant, multi-drug resistant sort of gram-negative bacteria. So these are very good killers of gram-negative agents here that actually will displace magnesium and calcium in the membranes and disrupt that, causing a bactericidal sort of effect here. So very broad gram-negative coverage. However, the main reason why we don't like to use this is going to be because it has a ton of negative side effects, and in fact has a lot of black box warnings for things like nephrotoxicity, neurotoxicity, can cause prolonged paralysis in patients who are say intubated, sedated, and then paralyzed. So a lot of issues there. Now, again, we've not really used it a lot because we came up with better drugs, things like the aminoglycosides, but because of these really resistant bugs coming back, we've had to start to use it again. So it's pretty rare, but you may see it done occasionally places like the ICU. More often than not, you may see it used for things like otic preparations or topical preparations, things where you don't see a ton of absorption. However, you still want to get that good bacterial kill on those sort of topical routes of administration. Okay, so that's it for the antibiotics. Moving into the antifungals next. So again, just like we mentioned with antibiotics being relatively selective for bacterial targets, you're going to find that our antifungals are relatively selective for fungal targets, right? This includes things like molds, yeast, dermatophytes, all these things here. And so you're going to find that their cell wall differs pretty significantly from both bacteria and from humans, right? They're actually pretty similar to my cell wall, because a lot of people have called me a fun guy before. So there's that. I'm sorry, it's a very bad joke. Anywho, but we will find that our antifungal agents are going to be working on these cells because they have different ribosomes, they have a very distinct different nuclear membrane, things like that. And you're going to find they don't really work, our antibiotics don't work on them, but we do have special agents that work very specifically on the fungal cells. So looking at the reason why people get fungal infections in the first place, right? Mainly it's going to be due to some change in the normal physiologic activity of the body, whether it be a loss of barriers like the skin. So say, for instance, you would have, say, an indwelling catheter, you have significant burns or surgery. It makes it easier for the fungus to take place, or at least to take hold. It could be due to immunodeficiency. So if patients lack the immune system to kill off the fungal cells, that could be a big issue there. Diabetes is another big one, just with them having kind of chronically high blood sugar. Fungus likes to eat that and then divide. In some cases, you may actually find that by giving antibiotics, you kind of remove some of that selective pressure on the fungus, and that allows them to kind of take hold as sort of an opportunistic infection. And then think about places, warm, moist environments. Fungus likes to grow in those areas too. So places like diaper rash and athlete's foot, you can think about these environments as being very hospitable to the fungi. And again, you're going to find that a lot of these infections you're going to run into are mainly going to be involving the skin, especially if you work in urgent care, or if you work in derm and things like that. However, the more systemic ones can be very, very difficult to treat, mainly because a lot of those patients, again, don't have a very competent immune system to deal with that fungal infection. So looking at some different fungi here. Now, again, I'm not going to get quite as in depth with these as I am with the antibiotics in terms of the different spectra of coverage of each antifungal agent. Again, these are things that you can probably look up just because they're going to be used a little less frequently. But again, looking at different types of fungi that are going to be causing issues here, you're going to find that some of them are going to be more invasive, causing more systemic mycoses, things like Aspergillus, things like Candida. Some of these are going to be more related just to subcutaneous mycoses, so again, a lot more like skin sort of infections here. And then this is where you find these superficial ones, where you find issues of hair and nail fungal infections. Trichophyton is a big common one. But again, you're going to find that different antifungal agents may have a different niche depending on its activity. So overview of the different classes of antifungal agents we're going to talk about. I'll get into each one of these specifically, but again, if you want to reference back to this list, so you at least know the different classes. So if you reference back to that picture of the fungal cell, you'll basically find that fungi or fungal cells have both a cell membrane and also a cell wall. And so depending on the agent that you're using, you can find that we'll actually be targeting different components of either the cell membrane or the wall. So as an example here, things like the polyenes, they tend to alter that membrane integrity and the permeability. Also, ergosterol is a big component of that cell membrane, and so by inhibiting ergosterol synthesis, you're going to basically disrupt that cell wall. The cell membrane, very similar to what we saw with our cell wall active antibiotics, things like your penicillins and whatnot. Other ones include things like inhibiting certain enzymes that are going to be responsible for producing that ergosterol. Again, less ergosterol, cell membrane disruption, thus cell death. And then things like the echinocandins can actually be influencing the cell wall specifically here by interrupting this D-glucans. So other agents may work on cell division specifically. So again, another common one we see used for a lot of topical fungal infections include things like griseofulvin, which actually inhibits the microtubules. So if you remember back to your studies of things like mitosis, you remember that the microtubules are really important for pulling chromosomes apart during actual mitosis when the cells are splitting apart. Or at least when the chromosomes are splitting apart. If you inhibit that, that's going to be a big way that we can prevent fungal cell replication. And so that's going to be one way we can deal with that. And then we could even interrupt the nucleic acid synthesis. Again, if you do that, you're going to be preventing DNA synthesis, and thus the cell will eventually die. So first one we'll talk about is going to be amphotericin B. Some people actually call this amphoterrible B because it has some pretty nasty side effects. This one's kind of interesting in terms of its mechanism of action. It can actually form a membrane through ergosterol in the actual cell membrane there. So by forming that pore, you're going to allow things like potassium and magnesium to leak out of the cells, and that leads to oxidative damage to the membranes and eventual cell death. Keep this in mind because you're actually going to find that this can affect our cells as well, sort of similarly. So there's a lot of different formulations of amphotericin B. You're going to find that some of these come in things like a lipid formulation. Some of them are going to have just the straight drug by itself. You tend to find that the straight IV drug is going to be much more likely to have side effects. The lipid formulations are going to have less side effects. They've actually been formulated to try to limit some of the systemic side effects because it can be so nasty. The most common one that I'm used to using is Ambisome, which is liposomal amphotericin B. You can see here it actually comes in a solution that has all these little phospholipid bilayers. This is just like our cell membranes, and it's actually impregnated with amphotericin molecules. And so by doing that, you can actually help to limit the amount of amphotericin that actually gets stuck on our cells and causes some pretty significant side effects. So again, I'm not going to get super specific on the indications here in terms of which fungal cells we're going to try to cover with this. Just know that amphotericin B is really reserved for more invasive infections, mainly because it is so effective but also really toxic at the same time. And so this is why we try to hold off on using it if needed. Those things you're going to see are going to be things like fevers and chills. A lot of this is due to stimulation of things like interleukins and tumor necrosis factors. A lot of times it'll look similar to an anaphylactoid sort of reaction there. So we'll pre-treat with things like Tylenol. We'll give antihistamines, corticosteroids, things like prednisone to try to prevent that from occurring. So they may get pre-treatment before each dose of this. The other big things you have to worry about are things like electrolyte abnormalities. This actually can interact with the renal cells and prevent the renal cells from reabsorbing potassium and magnesium, and so you end up losing a lot of that. It's called wasting, or electrolyte wasting, and that can lead to some pretty significant cardiac effects if that's not monitored for and corrected. You can see hypotension, you can see renal insufficiency. You really got to hydrate the patient really well whenever you give this. This helps to flush the drug out through the kidneys as fast as possible so it just doesn't hang out there and affect your renal cells. So that's really the big thing, is make sure you give it with lots of normal saline to try to flush that out through the kidneys. Another one that kind of fits in the same sort of category here, which we'll talk about a little bit more in the ENT section, is nystatin. This one's going to be a topical agent that's also used a lot for things like oral candidiasis. This one's nice because it actually doesn't get absorbed from the GI tract. So you may see it used topically, you may see it used orally, but it's not actually going to be able to treat any sort of systemic fungal infections, not like something like amphotericin B would be. However, very good because it's very limited in terms of side effects due to really, really poor absorption. Okay. Another one is going to be 5-fluorocytosine. Again, this is going to be one where it basically is going to prevent the fungal cells from producing their own DNA, essentially, right? So it's actually going to inhibit the thymidylase synthase, so it cannot produce new nucleotides. And so by doing that, you'll eventually lead to too many errors in the DNA, and that leads to the apoptosis there. Again, sometimes you'll actually see this being used in combination with things like Antifungal B for more like really severe sort of fungal infections here. So imagine a cryptococcal meningitis. I've already kind of alluded to the fact that bacterial meningitis is already difficult enough to treat just because the CNS is a very protected sort of site. But when you have something like fungus starting to take place in the CNS, that's a really big deal, right? So by combining with two different antifungal agents, sometimes you can get a little bit better penetration, better synergism with that, right? So you can just some indications. I'm not going to get really specific on the test in terms of the actual indications here, but certainly side effects, mechanisms of action, those are the things I want you to know about in terms of stuff for the test. Okay, other things you can see here. Now, I mentioned it inhibits nucleotide synthesis to inhibit fungal DNA synthesis. However, you're going to find it affects our cells too. And so that can mean things like bone marrow suppression because our bone marrow cells are usually turning over very quickly. So if they're not able to produce new DNA, that's going to be a problem for them as well. Things like hepatotoxicity can develop. So these are things to know. This one's only available orally, so it could be a problem if you had a patient who maybe could not absorb things orally, maybe due to something like C. diff colitis or some other condition that would prevent them from absorbing it. This is a big group here, the imidazoles and triazoles. Basically what they're doing is inhibiting the fungal CYP450. And this is really important because it converts the lanosterol to the actual functional cell membrane protein called ergosterol. And so the reason why that's really important is because you've probably already picked up on this, because it inhibits fungal CYP450. Guess what it can also do to us? Interesting. So anyway, we're going to use this for a lot of topical sort of applications here, things like tinea pedis, things like tinea corporis, etc. We can use it for certain nail infections or onychomycosis here. They get a lot of topical use. And again, this is nice because if you're using them topically, chances are they don't have a lot of systemic absorption, and thus you do not see any systemic side effects. It's not always the case, though, because some of them can also be used systemically. We'll see some instances of that in a moment. Ketoconazole is the one that you can see commonly used orally and topically. Probably more topically than anything else, but it can be used orally here. And the big things to know is certainly you can see nausea, vomiting. Okay, a lot of drugs do that, but it has very significant CYP3A4 inhibition. And so because it does that, you got to watch for drug interactions. There's going to be a million of them, because remember what we said about CYP3A4? You know, it's the most common one you're going to run into in terms of being responsible for metabolizing medications, right? Other things like itraconazole is an orally active agent here that has got a wider spectrum of antifungal activity, so it's starting to be used more frequently than ketoconazole for a systemic sort of purpose here. But again, you're going to find that it's going to be inhibiting CYP3A4. This one is actually teratogenic, so you couldn't use it in pregnant patients, right? So these are things you have to know here. Also note, whenever you have a patient with febrile neutropenia, usually when you're starting them off on empiric therapy, you always want to cover for a pretty wide range of antibiotics or of bacterial coverage. Typically, when you have a patient like that who's not responding well to the antibiotics and maybe they're not culturing anything out, very frequently you have to consider if it's something else like a fungal infection. Remember, when you send off for a bacterial culture, it's not going to tell you if there's any fungi there because the test is just not designed to do that. So that would be something you'd want to actually order separately if you thought you had a patient who needed fungal coverage in that case. Posaconazole is another one. This is being used for more invasive sort of fungal infections here. This one's really good as a kind of a backup if you have someone who has maybe a more refractory sort of fungal infection. Things to note, though, things like QT prolongation can happen here. That could be related to the hypokalemia that can develop with this, hypomagnesemia. So again, you want to make sure you're monitoring things like your basic metabolic panel, so you can catch some of these things before they become a problem. Maybe monitor the EKG if need be, right? Fluconazole, this is probably the most common one you're going to run into in terms of oral antifungal agents here. It has really good oral absorption and is used for all sorts of things. Not only that, but it can penetrate the CNS. So if you had someone with cryptococcal meningitis, this could be useful. It could actually be preventative in patients with AIDS who we know are at risk for cryptococcal meningitis. Because you vaginal application for this. If you had a vaginal fungal infection, really good for all these sorts of cases here. But again, note it's going to inhibit things like CYP3A4. This is a really common one. CYP2A4, not too many interactions associated with that, but something to note. And also could be teratogenic for people, plus minus. So that's one of those things there where you may want to avoid using it in pregnant patients unless you had a really good reason to do so. Voriconazole, this is actually a derivative of fluconazole and is very good for more systemic aspergillus and candidal infections here. And it's actually, this is nice because it lacks a lot of the side effects that you see with amphotericin B and is starting to be used as an alternative for those more severe systemic sort of infections there. However, gotta note, CYP450 interactions, really any of the triazoles are going to cause this to occur. You get some vision impairment, and actually another really interesting thing about this is that this is available both orally and IV. Actually, to get it into solution IV, you have to put it in what they call a cyclodextrin, which is basically this sort of donut-shaped sort of molecule that actually encompasses the drug that makes it more soluble. What's interesting with this is it actually is the same mechanism as Febreze. I'm sure you guys are familiar with Febreze. They can spray it on something stinky, and it will actually do the same thing. It will trap those the smelly particles within that donut sort of structure. Also, why you'll notice that as a Febreze gets degraded away, eventually the smell comes back because you didn't actually do anything about the smell. So I recommend not relying on this to keep your laundry smelling fresh. Just do your laundry, right? The problem, though, clinically here with voriconazole, though, is if you're using this IV, this can actually accumulate in patients with renal failure. Clinical impacts we're not quite sure of, but it's probably not good for that to accumulate. So very frequently we'll start them IV and then try to switch them to PO as soon as it's possible. Okay, there's a lot of topical agents here. Again, these are going to lack a lot of those systemic side effects that we mentioned, things like CYP3A4 inhibition, but clotrimazole, miconazole, teoconazole, these are probably the most common ones you're going to run into. And again, you can start to see some of them, what their uses are going to be. Things like Vagistat, obviously, is going to be for vaginal administration. Again, these are nice because some of them are just kind of one-time uses, which is very handy from a patient compliance sort of standpoint, right? Some of them require a little bit longer treatment, but some can get away with just a one-time dose. So that's the triazoles. Moving into the echinocandins, this is a little bit of a newer class of medications here. We have things like caspofungin, micafungin, and anidulafungin, otherwise known as Araxis. Basically, these are going to be inhibiting that conversion. They're going to be inhibiting that ability to convert that 1,3-beta D-glucan synthase. So that way you have less formation of the 1,3-beta D-glucan, right? So again, it's affecting that cell wall specifically. And so we're using this a lot for patients with very invasive and systemic fungal infections, things like Candida or Aspergillus. Again, seeing it used in febrile neutropenic patients and things like that. Again, being reserved because, again, we don't want the fungi to get resistant to these agents here. As far as adverse reactions go, again, you got to monitor for electrolytes. You got to look for things like blood dyscrasias because it can affect our cells as well. So just something to be aware of. Then griseofulvin, this is a very common one you're going to see used over in the outpatient realm here. I mentioned that this works by inhibiting the mitotic spindles, so it actually will stop cell division in the dermatophytes. This is mainly going to be used for topical application. Even though it's given orally, it's being used for topical fungal infections here. And so this is one thing I want you to know with this is that this is good for things like working the skin, the hair, and the nails. So even though this may be given orally, it's being used for those topical sort of applications. The big thing to note, though, is just look at the time frames you'd have to actually be treating for some of these. Some of these can have very slow growing and slowly replicating fungal cells, in which case you have to really treat, especially with the more kind of distant locations like the toenails, you have to require up to 12 months of treatment for. And again, you're going to find that treatment failure is quite common in this patient population. A lot of them do not stick with it, and so what happens? Well, the infection comes back, unfortunately. So griseofulvin is a very lipid-soluble sort of substance here, and so in these cases, we actually recommend that patients will take it with a fatty meal, so that way it will enhance the absorption. This is things like full-fat milk or things like butter, things like that. It'll help to increase the absorption there. In terms of reactions to note, you can watch out for things like mental confusion, especially in elderly patients. And note the induction here. Again, this is not inhibition, but induction of the microsomal enzymes, things like TYP2C9, that can be an important one for patients who are on warfarin. That may actually cause increased risk for clots, things like that. And then a couple of last ones here, the allylamines. This includes things like naphthene and terbinafine. These are actually inhibiting ergosterol synthesis by inhibiting the squalene epoxidase. And these are mainly going to be seen topically for the most part, but this is where you have things like Lamisil and Naftin. These are mainly going to be for those superficial dermatophyte infections, mainly for the fingernails and toenails. Again, note here the long treatment durations, because these infections tend to be very difficult to treat, mainly due to the slow-growing nature of them, and also sort of the distant nature. It's more kind of difficult to get the drug out to those areas, but even then, when you're using topical formulations, penetration can really be a big issue there. And again, tolnaftate itself, is distorting things like hyphae, and they'll stunt that mycelial sort of growth there. Again, you can see it used for a lot of these superficial onychomycoses, things like tinea pedis, tinea cruris, all these different types of infections. Really good. Again, topical only, so not a ton of systemic side effects you'd be worried about. The next group I'll talk about real quickly is the antihelminthics. Obviously, this is going to be helping to deal with worms, and so we have a couple of different agents here. We have things like Imidazoles, things like albendazole and mebendazole. Okay, these are actually working to inhibit the formulation of microtubules in helminths, and also blocking glucose uptake. So they can't do either of those, and parasites are eventually going to die. And so you can use this for things like hookworms and roundworms and pinworms, all these sorts of things. Nice thing about this is it's very well tolerated. Not a lot of issues here, because again, a lot of times this is in pediatrics we're having to use these agents. But you can see some hypersensitivity as a risk, and rash could be a problem here, which could be including things like Stevens-Johnson syndrome and toxic epidermal necrolysis. However, it's pretty rare. Another one called parental pamoid, or PinX. This one's actually interesting because it works by releasing acetylcholine and then inhibits cholinesterase. So you basically end up having a ton of extra acetylcholine around that affects all of the nicotinic acetylcholine receptors, which basically leads to all the receptors kind of desensitizing, and so you cause paralysis and death in the worms themselves. So they can die a slow, painful death, those dastardly worms. But mainly for things like pinworms and hookworms. Again, very well tolerated. Not a lot of crossover activity between our patients and the worms there. So that's it for this section. If you have any questions, please let me know, and I'll be back in just a moment when we'll cover our ENT section. Thanks a lot. Bye.